Amazing. So I'm not an obstetrician or a gynecologist, but I see a lot of ladies and gentlemen with osteogenesis imperfecta. And this whole webinar, this whole idea about doing some women's health stuff, I think is really key. I think I totally agree with this idea of breaking down the stigma of talking about periods and pregnancy. I mean, pregnancy and contraception, probably people don't mind talking about, but, cervical smears and menopause and, why shouldn't we talk about all those things for any of us, and more specifically for people living with any form of disability or long-term medical condition. So you might have to excuse me, or forgive me, I'm going to do some fairly basic background because I didn't want to assume any knowledge. But I'm going to pull out some OI specific things. So when we think about contraception, and I really did take it back to the basics, there are lots of different ways we can think about it. So there are hormonal methods, and loads of these things will be really familiar to you. So in there, we've got the pill, we've got the progesterone-only pill, which is the mini pill, implants, injections, patches, a vaginal ring that I didn't know about till this week, which does exactly what it sounds like. It's a ring that goes up inside the vagina and it releases hormones. You change it once a month. And I didn't know that existed. So you've all educated me by me preparing. Then we've got long-acting reversible things. So these are things that are going to last sort of weeks to months. So things like patches and the coil and all those sort of things. Then we've got barrier methods. You'll be familiar: condoms, female condoms, diaphragms, caps, those sort of things. So they're literally methods that just create a barrier so the sperm doesn't get to your egg, so you're not going to fall pregnant. Obviously, we've got permanent methods that I'm probably not going to go into too much, very personal choice, but sterilization for women, vasectomy for men. Natural family planning, so fertility awareness, that's knowing where in your cycle you are and mapping that out, and then not having sex when you would be most likely to fall pregnant. And then lactation amenorrhea method basically means when you're breastfeeding a baby and you're not having periods, you are really a lot less likely to fall pregnant. And just a mention of the emergency morning after pill, which is still a form of contraception that you can use 3 to 5 days out after unprotected sex. So the question I get asked most commonly in clinic is which is safe and which is okay in OI. And if you take nothing else away, the only contraceptive choice that I would try and get people to avoid in OI is the injection. And that's also called Depo-Provera. And the reason for that is that medication has a link to reducing bone density in anybody who takes it. So why would somebody with osteogenesis imperfecta choose that one? Probably not the best idea. The rest will not impact bone health at all. So really, like my favorite childhood book, you can choose. So how are you going to choose? And this is the same for all women. So how well does it work at preventing pregnancy? So like if getting pregnant is the worst thing in the world you can ever imagine, then you want to choose something that's really good at preventing pregnancy. Then you might want to think about how is it used? Like, do I have to use it every time I have sex, or is it really infrequent that I have to think about it and that would be better? You might think about side effects and risks. You might think about effects on periods. We've already talked about them, and some of these methods of contraception will reduce your periods. And just to say, you might be looking and saying, actually, the most important thing for me is that I don't catch any sexually transmitted infections. Only condoms of any method of contraception are going to prevent sexually transmitted infections. And I just want to big up the NHS website here, because I went through this and it is just really clear and really helpful. So it's a really valuable resource to look at. And I stole this next table, which is now not going to show, which is annoying. My computer appears to have ground to a halt. Bear with me. Let's try this way. There we go. So This is just to show you, and you'll see that in every table, I've left the injection in, but I've made it red because we're going to try not to do that. So you can see that lots of these are really effective. So perfect use is if you use the method of contraception perfectly every single time. So for the pill, as an example, the combined pill, you take it every day at the same time of day. You never have an episode of diarrhea. You never throw up, all those things. So you can see that lots of them, if you use them perfectly, are over 99% effective. Typical use talks about what's actually realistic, which is you don't always take your pill at the same time every single day, and you might occasionally have an episode of diarrhea or something like that. So this is typical use. So this is more realistically, and as you can see, the sort of longer term things like the implant and the coils are the most effective, and as we come down, we get less effective. I would say, and this is my personal opinion, natural family planning is not an effective way of trying not to have a baby. I totally appreciate that some people will choose it, but I don't think we can really rely on that. Interestingly, there's no data on diaphragms and caps. I think they've kind of slightly gone out of fashion with all the other newer things we've got. So then you might think about, how am I going to use it? So obviously a condom you have to use every time you have sex. A pill you've got to take every day. Whereas if you had a hormonal coil, so the sort of things that you might have heard of are things like the Mirena coil, you don't have to think about that for maybe 5-6 years at a time. The contraceptive implant, 3 years. So how often you use it might be something. And the other thing is, who's involved? Is it something you have to do yourself, or do you actually have to see a doctor or a nurse, or get an appointment at a clinic, get to a clinic, all those sort of things? And then I think also, particularly for OI, if we're thinking about some of these, it's going to be around how easy is it for you to use that method of contraception. So to physically use something like a diaphragm, where you have to be able to put that into your own vagina, that or the vaginal ring, that may be difficult. Equally, something like a coil might be tricky at times for a doctor or a nurse to fit that for somebody with osteogenesis imperfecta, depending on the shape of their pelvis. So like with lots of other things, discussions, and there are ways and means to get these things done. But these are all obviously different people have different issues with this. Right, I've given up on that screen. Let's do it on this one. So just briefly thinking about side effects, that's another way that any of us choose how things are going. So the hormonal things, probably lots of people on the call are aware, might give you a headache, might make your boobs feel a bit sore, you might gain a bit of weight. There is a slight increased risk of blood clots and breast cancer with some forms of hormonal contraception. And then, like, if you have a coil put in, that might be a bit painful afterwards. There's a small risk of infection. And then the last thing that might influence your thoughts on it are the effects on your period. So there are some that will help with, there's a slight difference between what's going to help with a painful period and what's going to help with a heavy period. Probably the best for that is going to be the hormonal coil, something like a Mirena coil. But the pill is also good for that. And then the copper coil, the old-fashioned coil, can make your periods more heavy and worse. So we're weighing up all these things. And just a note on where we can go to get contraception. Again, the NHS website was really good for this. So literally, this is a screenshot of a button on the NHS website. But just to say, you don't have to go to your GP. There are lots of sexual health clinics, which aren't just for people who might have a sexually transmitted illness. They do loads of family planning and contraception. There are some young people's services available. My daughter she's 19, she goes to a young people's service where she just rings up the week before, makes an appointment and goes in and gets it, and there's no shame, and it's all nice and comfortable and aimed at young people, so that's perfect for her. She doesn't have to go to a GP at all. Some pharmacies can actually provide the contraceptive pill directly. to you as a patient. And actually, I don't know the age of anybody on the call, but if you're under 16 or you've got people under 16, discussions about contraception are confidential unless the healthcare professional thinks you are at risk of harm. So if you're young and you want to go and talk about contraception, go for it. It is confidential. No one's going to ring your mum or dad and tell them about it. And apologies to the parents who might find that a bit freaky, but it's really important. So coming on to pregnancy, and this is where, and now I've totally forgotten the name of the previous speaker, so I apologize, but your story was amazing. So knowledge is power. I love this quote from Francis Bacon. The more you know and the more discussions you have early and the more conversations you have, the better these outcomes are likely to be. Genetic diagnosis is now available on the NHS for anybody with osteogenesis imperfecta to be able to help them with family planning decisions. So you can ask to be genetically tested because that will inform the options you have. My advice would be start those conversations early. Don't wait. And genetics counselling services can be really helpful. But just to basically summarize what there is, so usually if you naturally conceive, there's going to be a 50-50 chance of the baby having OI. If you naturally conceive and you want testing, that can happen while you're pregnant, but some of the tests have a small risk of miscarriage. And now for OI on the NHS, you can have, if we know what your spelling mistake is in your usually collagen genes, then you can have IVF and they test the embryos and only implant the ones that don't have OI. This is a really personal choice, but it is available. So we already talked a little bit about how safe, can I safely carry a baby? This is another question. So in the milder forms of OI, it's rare for this to be a problem. In the more severe forms, again, we might think about pre-pregnancy counselling. We would monitor a little bit more intensely, and we, in that scenario, would think about an elective cesarean section. I apologise for this busy slide. I probably should have laid it out a bit better, but I looked in the scientific data to see what does science or what do our papers say? And these are the sort of 4 top papers from the last 5 years or so. So having a cesarean doesn't reduce the risk of fractures in a baby at birth. So if your baby has OI, it doesn't really matter whether you have a cesarean section or a normal vaginal delivery, but we would use the same reasons that we would choose for anybody. So for example, if you have an abnormal pelvis. Maternal fractures do happen. And in this one paper, they thought it was more common if you were breastfeeding. That's my alarm telling me to shut up because I've spoken for long enough. So you might want to think about controlling modifiable risk factors, and I'll talk about them. There was this survey of 132 women that reported higher rates of cesarean section. That's no surprise, but possibly increased fractures, bleeding, diabetes, and issues with the baby. But there's also been this bigger study, which is actually the best evidence that we have at the moment on pregnancy outcomes. And they looked at 433 pregnancies. There were more cesarean sections, but actually the rates of complications were very similar to a reference population. This was in Denmark, where they collect brilliant data. So I think the reassurance here is that with planning and thought, it can be entirely possible. And actually, you probably don't have a much greater risk of complications. Obviously, complications can happen in any pregnancy. So what if you're thinking about a pregnancy? So the general advice is the same for everybody. Things like folic acid, not smoking, drinking, thinking about medicines. If you're on a bisphosphonate, that would need to stop. OI specific advice would be talk to your team early. If you don't have a team, try and get a team, or talk to your GP about referring you to somebody. Genetics clinic would be great. Genetic testing, counselling around that, and we refer regularly to genetics counsellors who will meet with you and your partner to explain things to them and problem solve. Maternal medicine services are more frequently As somebody with OI, you probably wouldn't get what we call midwife-led care. So there would definitely be doctors involved in your pregnancy. And obviously we want to make sure you've got enough calcium and vitamin D. So that brings me to the end of my slides, and I will stop sharing.